Thanks, Dr. Greep and audience, for your attention. That was a great review, Nick. The work that I'm going to now present is on behalf of my friend and partner, Roy Greenberg, who couldn't be here to give this talk today, but everything I present today is based on his genius and groundbreaking work. As we know, thoracoabdominal aortic aneurysms, even at centers of excellence, carry a relatively high mortality compared to the other operations we do for cardiovascular disease. Much of that is because these patients are older and have serious comorbid conditions. In an attempt to become better at treating more complex aortic disease, endovascular technology has evolved. You can see the image on the left is a patient with a juxtarenal aneurysm, and circa 2000, the vascular surgery team at our institution was pushing the limits of these devices by doing things like putting stents across the bare metal portion of the device to get the devices as close to branch arteries as possible. Over time, these devices became fenestrated, that is, they had holes to accommodate these branch arteries. And these initial devices were used for juxtarenal aneurysms. As you can see, circa 2003, the image on the right, there's access into those renal arteries. And so juxtarenal aneurysms are commonly treated with these devices now. The way that this is performed is a main body device is placed in the aorta. It's custom designed with a hole to accommodate the branch. And then a second device, so it's a modular system, is placed into the branch artery, and after its delivery, it's flared on the back end with a balloon. For some reason, the video stopped. But after gaining experience with these fenestrated devices for juxtarenal aneurysms, the technology was expanded to what's called branched graft devices, where not only is a hole made to accommodate the vessel for a bare metal stent, but the holes were then reinforced with nitinol wire to create a branch. So similarly, the main body device is placed into the aorta. Access is obtained into the branch vessels, whether it's renal, celiac, or SMA. A larger balloon is blown up on the back end of that covered stent component for the branch vessel, and it's flared on the back, thereby creating a riveting between the two components of the devices, which allows us to do operations like this, a totally endovascular thoracoabdominal aortic aneurysm repair with 4 branches for the celiac, SMA, and both renal arteries. This patient had a previous aortobiliac reconstruction in the past. Well, we reported our initial experience with 73 of these patients 5 years ago now, and you can see that these patients had large aneurysms, and they were sick patients with serious comorbidities of cardiac dysfunction. 20% of them were on home oxygen, and a lot of the patients had renal dysfunction. The devices were constructed, again, in a modular system based on the Zenith thoracic stent graft with either these reinforced fenestrated elements or what's called a directional branch, where a helical limb of an 8mm graft is attached to the device, and notice the gold markers on these to allow for fluoroscopic guidance and imaging, or a combination of both types of components. In that initial experience with 73 patients, there was excellent survival at over 80% at 2 years, and even more important was freedom from aneurysm-related mortality was 90%. Out to 2 years. These patients still had complications like stroke and spinal cord injury, respiratory and renal failure, although these rates were quite low. What was really remarkable is that in this initial experience, if a patient didn't have any of those serious complications, they were out of the hospital in 5 days. What we saw in follow-up is confirmation that this endovascular repair actually works by reversing the natural history of disease. This is a patient whose aneurysm was over 10 centimeters in presentation, and after exclusion, you can see in just 1 year, it's shrunk by 3 centimeters. So this initial experience established endovascular thoracoabdominal aortic aneurysm repair in our institution. We still apply it to high-risk or non-operative patients. Complications were not eliminated, but we had excellent outcomes. And at this point, the ID has continued to be improved to enroll 1,000 patients. In 2000, Roy and the team published their updated experience with over 600 patients. 406 were categorized as thoracoabdominal aortic aneurysm patients, and 227 of those juxtarenals. And you can see that overall hospital mortality was less than 6%, and especially low in the type 4 thoracoabdominal and juxtarenal aneurysm patients. And 2-year survival was maintained satisfactorily in this high-risk group of patients. Paraplegia rates were relatively low, and graft patency was excellent, nearly 98%, with 15-month CT follow-up. What about the risk of spinal cord injury in these patients? Well, because we were able to apply endovascular therapy to patients with similar extensive aortic disease, we were able to compare the open and endovascular approaches. And we published this paper a couple of years ago where we compared patients based on the extent of involvement of disease or the extent of aorta that was treated. And we found no difference in their mortality, whether they were open or endo, not only acutely, but in follow-up. But more importantly, we found also no difference in spinal cord injury in these patients. The only thing that was most closely correlated with spinal cord injury was the actual extent of aorta that was treated, whether it was open or endovascular. Well, again, as I said, we initially applied this to non-operative, very high-risk patients, and I think we still do that. We found that patients with extent type 2 aneurysm disease seem to be higher risk. Patients with other comorbidities, certainly emergency indications. But some could argue that thoracoabdominal aortic aneurysm, by definition, is high risk. There are limitations to these branch grafts. For now, they still require a customized design, which limits its use to mostly elective cases. It's unclear how durable they really will be, and that's why we still apply them to older and sicker patients. And the operation is still quite complex, although I'll show you some of the steps that we've taken to address these limitations. We've improved our imaging techniques using automated sizing software programs that have been developed in our institution. We use DynaCT to perform intraoperative CT scan on these patients to reduce some of the radiation load and to simplify the procedure. There are versions of these devices that can be standardized for portions of its construction, which speeds up the access to the devices. And the delivery systems have been modified to ease their use as well. This automated sizing software, which was designed by Dr. Gohl in our institution, demonstrates that when compared to the manual sizing, on average, there's only about a 1 millimeter difference in all the various measurements that are made, whether it be the location of the branch vessels, their length measurements in relation to each other, and all the other detailed sizing that's performed. Intraoperatively, we use the DynaCT to create a fusion imaging technique, which simplifies the process of getting access to these branch vessels through the component. You can see the overlay on the left-hand side, which makes accessing the vessels much better and has allowed us to reduce the radiation exposure in these patients by half. And these devices continue to evolve into a more standardized design. For example, this particular design, where there's 2 helical branches to accommodate the celiac and the superior mesenteric artery, because there's some freedom when you cannulate these helical branches, you can accommodate nearly 80% of patients for those 2 very difficult vessels. Is it possible to add an in situ fenestration for the renal arteries and have a truly off-shelf device? Well, the team, Dr. Tudor's team in San Francisco, has done similar work. They also have an off-the-shelf design. They don't use the helical branches, but they have a short component. You can see the image of the device on the right where there's 4 branches to accommodate the vessels. And using CT scan criteria, they found that using this standardized design, they can match that device to 85% of patients that were screened in one study. And a currently available off-the-shelf design for treating type 4 thoracoabdominal aneurysms or maybe pararenal aneurysms, depending on how you describe it, has a scallop for the celiac artery and then fenestrations and these mobile branches for the renal arteries, which allows some flexibility to access those 4 vessels in a large proportion of patients. And Gustavo Oderich and his team at the Mayo Clinic, who learned how to do this procedure from Roy and our team in Cleveland, has a growing experience where he'll take an off-the-shelf Zenith thoracic stent graft, spend a fair amount of time, but build the customized device for his patients on the back table. We've done this in a couple patients in our institution for emergency situations. And then, of course, there's these other creative and really unclearly durable options for patients using off-the-shelf combinations of commercially available devices where sort of branching and modular use of systems are used to treat patients. But some of the other limitations of these branch devices are in patients with aortic dissections. Patients with arch disease present issues with proximal sealing. The distal target vessels need to be accessible from the true lumen, and so that offers some difficulty in patients with dissections. And the true lumen needs to be big enough to allow for both axial and longitudinal manipulation of the devices so that they can be positioned accurately. So having said that, the chronic dissection patients were initially a contraindication for the use of these devices, and so we've done things like hybrid operations, which have allowed us to treat patients with thoracoabdominal dissections with endovascular solutions. But as we've gotten better with these devices, there have been select groups of patients with chronic aortic dissections where we have been able to apply the branch graft systems to their disease. And I believe the count is now up to 28 patients, although there may have been a couple recently where we've placed branch grafts into their chronic dissections and allowed for a good distal seal. Some of the other endovascular solutions that we've explored is placing devices into the false lumen to cork the false lumen and eliminate retrograde filling of the false lumen from below to treat that thoracoabdominal aorta. And so this diagram demonstrates our patient selection process at the Cleveland Clinic. Open thoracoabdominal aortic aneurysm repair is never limited really by the anatomic complexity of a patient, but can be limited by the patient's operative risk. And so you see that bar on the bottom. The totally endovascular thoracoabdominal aortic aneurysm repair is excellent for patients who are high risk, given that their anatomy is amenable to the device. The patients in the upper right include a lot of patients that Dr. Miller referred to, that sort of cohort C, who we probably either shouldn't touch. But many of them, because of anatomic complexity, we can come up with some creative solution using hybrid techniques. It's the gray zone in between that seems to be shifting and will continue to shift over time as our experience with the branch devices for thoracoabdominal aneurysms improves. We'll probably be applying that technology to a more moderate risk group of patients. You can see that this slide demonstrating our experience with nearly 600 patients with thoracoabdominal aortic aneurysms in the last 3 years, that 2 out of 3 undergo endovascular surgery. And you can see the distribution between types of thoracoabdominal aneurysms, that the majority of type 3 and type 4 thoracoabdominal aneurysms are treated endovascularly at our institution. The types 1s and type 2s still, we prefer open surgery for most of those patients. Many of them are young. What also I think is remarkable to demonstrate is that with this team approach and this multimodality approach to these patients, we've been able to keep our mortality for elective repair, whether it's open or endovascular, around 3%. Of course, emergency operations still present high risk, and we need to improve our ability to provide these patients with other options. But in conclusion, I would say that all thoracoabdominal aortic aneurysms present a high-risk population of patients. As we develop these new technologies, we'll be able to expand options and expand that patient pool. It's important to understand in aortic disease in general that open and endovascular therapies should be thought of as complementary to each other, and that using hybrid approaches may provide a reasonable option in patients who are particularly complex. These off-the-shelf techniques will continue to evolve over in time, and eventually, I believe that endovascular solutions for the thoracoabdominal aorta will become the primary treatment option. Thank you very much.